The following podcast is part of a certified educational activity titled The Power Sequence of RRMM, Collaborative Approaches for Optimizing Sequential Treatment with Cellular and Off-the-Shelf Immunotherapy. Access the entire activity and complete the post-test at peerview.com/PAT860. Downloadable slides and practice aids are also available.
Hello, I'm Dr. Jonathan Kaufman from Emory University School of Medicine in Atlanta, Georgia. Welcome to the Power Sequence in Relapsed Refractory Myeloma, Collaborative Approaches for Optimizing Sequential Treatment with Cellular and Off-the-Shelf Immunotherapy. Today, I'll be exploring where we currently stand with BCMA and non-BCMA immunotherapy in multiple myeloma, focusing on how these modalities are being used across different stages of relapse. We'll also take a look at where the field is headed with newer targets and combination strategies and what all this means for our real-world clinical practice. Along the way, I'll share insights on how I think about selecting and sequencing these therapies and offer key strategies for managing dosing and safety while improving care coordination across the team. We've developed downloadable practice aids collecting information on these topics, so you might want to access them now. Okay, let's begin. CAR T cells first arrive in 2021 and 2022 with the ide-cel and cilta-cel approvals for relapsed refractory myeloma in the later lines of therapy, with 4 prior lines of therapy. We then had both BCMA and GPRC5D CD3 bispecific antibodies with teclistamab, elranatamab, and talquetamab. In 2024, a very important year in the development of CAR T-cell, especially earlier in the course of therapy. Ide-cel was approved in patients who had 2 prior lines of therapy, and cilta-cel was approved in patients who had 1 prior line of therapy. And in 2025, we've seen the reappraisal of belamaf with approval in the United Kingdom and anticipated approval in the United States. And we've also seen approval of the 3rd BCMA bispecific, linvoseltamab, in both the EU and the United States. Real-world data show progress in myeloma has lagged behind the science. We have new therapies, but outcomes have lagged. You'll see here with the Flatiron Health EHR-derived data in patients with relapsed refractory myeloma, those individuals who are refractory to lenalidomide and the CD38 antibody, approximately 50% of them were retreated with the same drug class. Very few of the patients received BCMA-targeted therapies, and at this time period, no patients received BCMA CAR T-cell therapy. And you'll note here in their data set, progression-free survival and overall survival were very poor. What are we going to learn today? We'll review the current guidelines and long-term evidence that continue to support the integration of BCMA CAR T-cell in early and later myeloma relapse settings. We're going to talk about BCMA antibody-drug conjugate therapy that may once again be available and offer an alternative treatment pathway for some patients with relapsed refractory myeloma. We're going to look at both BCMA and non-BCMA bispecifics, and that they have a clear role as an off-the-shelf treatment in heavily pretreated myeloma. And finally, we'll look at new bispecifics, new combinations of bispecifics, and a new concept, trispecifics, that show encouraging results in early investigation. Current NCCN guidelines for patients with relapsed myeloma are really broken down into the refractory status of the patient. Those individuals who are refractory to anti-CD38 antibodies like daratumumab, cetuximab, combinations like KRD, KPD, PBD, and others are NCCN approved. Those patients who are bortezomib refractory, we can look at triplets again with daratumumab or cetuximab in combination primarily with lenalidomide, pomalidomide, and carfilzomib. We also think about non-anti-CD38 monoclonal antibody regimens like KRD and KPD. For those patients who are refractory to lenalidomide, we have, again, triplets with daratumumab and cetuximab, like combinations with bortezomib, carfilzomib, and pomalidomide, and again, regimens like PVD, KPD, ELO-PD, and exacimib plus PD. Which leads us to the two new CAR T-cell therapies supported by CARTITUDE-4 for cilta-cel and KarMMa-3 for ide-cel. Again, cilta-cel is approved for patients with one prior line of therapy that included an IMiD and a PI and refractory to lenalidomide, and ide-cel is approved for patients with two prior lines of therapy that had to include an IMiD, a PI, and an anti-CD38 monoclonal antibody. The CARTITUDE-4 clearly demonstrated, compared to standard of care, and the standard of care was a combination of darapom-dex or darabortezomib-dex, that cilta-cel has a superior progression-free as well as overall survival in patients with standard risk disease as well as patients with high-risk disease, including patients with extramedullary disease. For patients who are in late relapse, we have multiple CAR T cells again approved. These were the initial approvals. Cilta-cel approved based on the CARTITUDE-1 study. Patients have had to have at least 4 prior lines of therapy, again, including an anti-CD38 monoclonal antibody, a PI, and an IMiD, and as well as ide-cel, again, supported by the KarMMa-2 study. There are now actually 4 bispecific antibodies approved for the treatment of myeloma in this late relapse setting. Elranatamab, teclistamab, and linvoseltamab are all BCMA targeted therapies, and talquetamab is a GPRC5D bispecific antibody. Belantamab mafodotin it can be accessed through an expanded access program. Cilta-cel was initially approved based on the CARTITUDE-1 study in patients with mostly triple-class refractory disease. And this update at ASCO 2025 and subsequently published and highlighted in the New York Times showed that 33% of the patients, and again, these highly refractory patients, remain progression-free for greater than 5 years after a single cilta-cel infusion with no maintenance therapy. And in fact, approximately half of the patients were alive greater than 5 years later, again, after a single cilta-cel infusion with no ongoing maintenance therapy. In fact, a subset of the patients who were progression-free were all MRD negative as well as PET scan negative 5 years after therapy. Where are we with BCMA antibody drug conjugate therapy in relapsed myeloma? Again, we have CAR T-cell therapy with cilta-cel and ide-cel, bispecific therapy, as well as belantamab mafodotin. Belantamab mafodotin is an immunoconjugate targeting BCMA with a multimodal mechanism of action. Belantamab delivers the cytotoxic payload, MMAF, for direct myeloma cell apoptosis, as well as immune mechanisms through ADCC and ADCP associated with an immunogenic cell death. And so belantamab mafodotin represents an off-the-shelf BCMA-targeted therapy that can be very effective in patients with relapsed disease. And 2 recent studies really highlighted belantamab mafodotin in combination with therapies. And what's really important about both these studies, the DREAM-7 study and the next study I'll show you is the DREAM-8 study, this was really a 3-drug versus 3-drug therapy, really highlighting the individual benefit of the addition of the BCMA ADC belantamab mafodotin. You see here in patients with relapse disease when Bela plus bortezomib dexamethasone was compared to Dara plus bortezomib dexamethasone, a really dramatic improvement in progression-free survival, median progression-free survival of 36.6 months versus 13.4, as well as an improvement in median overall survival. And then if you look at the subsequent lines of therapy after BVD or DVD, which included things like anti-CD38 monoclonal antibodies, pomalidomide and carfilzomib, the PFS2 maintained, demonstrating that using belantamab mafodotin earlier does not inhibit further anti-myeloma therapy. And again, I had mentioned previously that DREAM-8 study, which compared belantamab mafodotin with pomalidomide dexamethasone compared to pomalidomide plus bortezomib and dexamethasone. And again, we saw a very impressive improvement in progression-free survival, median progression-free survival in the belantamab pom-dex arm of 32.6 months compared to the median progression-free survival in the pom-bortezomib dex arm of 12.5 months. So an estimated 18-month PFS of 63% versus 41%. So what we've learned about targeting BCMA with an antibody-drug conjugate is that using earlier in the line of therapy, that you can combine it with standard therapy like pom-dex and bortezomib dex and really get great outcomes. Where are we with bispecifics and the evidence of an off-the-shelf either BCMA or GPRC5D combination? Bispecifics work in a unique way by combining, by targeting both the myeloma cell, again, either through BCMA or GPRC5D, and the CD3 cell, the CD3 positive T cell. It activates the T cell, it creates an immunologic synapse, and then it's associated with myeloma cell death. There are now 4 bispecifics approved in myeloma, 3 that target BCMA, teclistamab, elranatamab, and linvoseltamab, and 1 bispecific antibody, talquetamab, that targets GPRC5D. All of these are approved, at least in the United States, in patients who've had at least 4 prior lines of therapy. And again, as we go through this data, the teclistamab was supported by the Majestic 1 study, elranatamab was supported by the Magnetism MM3 study, talquetamab by the Monumental 1 study, and the linvoseltamab by Linker MM1 study. There is really exciting new combination data in the Redirect TT1 study, looking at combining both BCMA and GPRC5D bispecifics in patients with myeloma. And you'll see here, this was published in the New England Journal of Medicine, and the combination, whether you look at the recommended phase 2 dose or all levels, works in a very high fraction of patients with a significant number of patients who achieve a CR. And if you look at the duration of response, especially those patients who are in the recommended phase 2 dose, was over 80% at 2 years. Now, one area of a highly unmet need is those patients with extramedullary disease. And this study very carefully looked at extramedullary disease and divided it from paramedullary coming from the bone, but extramedullary, truly a plasmacytoma that's not related to underlying bone disease. And you see here the combination of talquetamab and teclistamab was associated with an almost 80% response rate. And the time to first response was in the first 2 to 3 months. The time to best response was in 5 months. And the estimated PFS for this really high-risk group of patients at 1 year was 61%, and the median progression-free survival was over 15 months. Linvoseltamab, again, that's our newest BCMA bispecific, again, shows encouraging efficacy in relapse refractory myeloma. Linvoseltamab, in contrast to the other 3 bispecifics, is given intravenously at a recommended dose of 200 milligrams. When you look at the overall response rate, it's 71%, with 52% achieving a CR. The duration of response was a really impressive 29 months, and the median progression-free survival has not been reached. So we saw deep and durable responses in subgroups of patients with pentarefractory disease, as well as patients with markers of high disease burden, like bone marrow plasma cells greater than 50%, and high levels of soluble BCMA. So the other thing that, again, just like we saw with belantamab mafodotin, is people are starting to ask the questions, can we combine these drugs with other agents? And so there's a lot of clinical trials. And recently we saw 2 clinical trials at ASCO 2025 that combine linvoseltamab with proteasome inhibitors, whether it's carfilzomib and bortezomib. And you see really impressive response rates of 90 and 85% respectively. And so the concept of combination with bispecifics is coming. We don't see data here, but we're also really excited about the combining of bispecific antibodies with our IMiDs, and as well as the newer class of IMiDs that we call cell mods, and we'll see data for this in the future. In my mind, the most exciting data that came out of ASCO 2025 is this new emerging trispecific antibody. The drug is labeled J&J 5322, which is a single molecule that targets both BCMA as well as GPRC5D, as well as binding in a low affinity manner to CD3. And so hitting 2 targets at the same time. And in this phase 1 study, again, the median prior lines of therapy was 4. With 126 patients, the overall response rate in those patients at the recommended phase 2 dose was 100%. In the 27 patients that had the medication at the recommended phase 2 dose, and 96% of those patients had a VGPR or better. And the 12-month PFS at the recommended phase 2 dose is 95%. And really encouraging, we saw, because of the attenuation, we saw a lower incidence and severity of the GPRC5D adverse events versus what one would expect with talquetamab, the current approved anti-GPRC5D bispecific antibody. So how do we make decisions about using all the CAR T-cell or off-the-shelf immune therapy? So a group of from the International Myeloma Working Group got together and came up with some core concepts. And I think this is a really important publication that it educates us about how to sequence these medications. When we're thinking about therapeutic considerations before a T-cell redirecting therapy, one, there's no concern about the use of proteasome inhibitors, IMiDs, steroids, or naked monoclonal antibodies like daratumumab or isatuximab or elotuzumab. We do recommend a 2-week washout period before apheresis or before your first bispecific dose. If we try as much as possible to avoid collecting mononuclear cells for CAR T-cell production while on a bispecific antibody, and if it's unavoidable, try to wait at least 4 weeks. We also try to avoid high-dose alkylating agent therapy or bendamustine prior to CAR T-cell or the bispecific antibodies. From a bridging therapy perspective, I strongly recommend try to get disease control prior to CAR T therapy. Whether or not in the long run that improves progression-free survival outcomes is yet to be determined, but there's really little doubt that it decreases the toxicity of the CAR T-cell therapy in the context of a lower burden disease. When we think about bridging therapy, one wants to use short-term, low toxicity regimens without known resistance. From a therapeutic sequencing perspective, if both treatments are options, a BCMA T-cell directed therapy is preferred over an antibody drug conjugate when both options are available. As we see more and more data about antibody drug conjugates, I think this might be one of the more controversial recommendations made from this document. CAR T cells preferred over the bispecific antibodies due to better post-progression options, primarily because CAR T cells is given once, whereas the bispecifics are given continuously, creating more of an opportunity for developing resistant disease. And then in a large part, rapidly progressing patients, it's very hard to get these patients on a CAR T cell, and these patients primarily are going to get therapies like bispecific antibodies. When we think about post-CAR T cell and bispecific antibodies, both BCMA and GPRC5D therapies are active. In general, giving a bispecific antibody after a CAR T cell shows fewer durable responses. That doesn't mean one can't do it, but just have to understand that it's less likely to have that long, durable response. And then if there's progression on a BCMA bispecific, then switching to another mechanism of action or a different target is recommended. So now I want to go over a few cases. And these cases are really the cases that we live every day with our patients. This is a patient with early relapse of myeloma. 63-year-old gentleman with standard risk myeloma, very good treatment, combination of DARA, VRD, induction, consolidation with transplant, achieved a VGPR post-transplant, and was placed on lenalidomide maintenance. Unfortunately, he progressed after 2 years with clinical symptoms and a rise in M protein. Whenever I see a patient now who has early relapse, and I believe that historically we called early relapse 18 months after transplant, but now with 4-drug induction therapy, I think we're going to expand that from 18 months to 2 years and possibly even 4 and 5 years. Because remember, when you look at the Perseus data, the 4-year progression-free survival was 84%. And so the percentage of patients who are progressing within 4 years on a Perseus-like regimen is only 15 or 16%. So the first question that I ask when we look at a patient like this is this a patient a candidate for a CAR T? And as long as this patient has the support system and the overall health, then I believe absolutely this patient is a candidate for CAR T. And we really, and as soon as we identify this patient has relapsed, we need to start planning on collecting therapy, planning our bridging therapy, and moving early with CAR T cell therapy. From a toxicity perspective, there are unique toxicities associated with CAR T cells, and there are unique toxicities also associated with bispecific antibodies. With CAR T cells, we see the majority of patients get CRS, and they're primarily low grade, grade 1 and 2. And what's unique about these medications is that the timing of presentation is different. Ide-cel happens very early, usually in the first 24 to 48 hours, and cilta-cel, the CRS, the median day of onset is day 7. ICANS in both is uncommon. Approximately 1 in 5 patients will develop ICANS, and it's typically, again, low grade and rarely serious and life-threatening. Infections are common, and we have to be conscientious about that. Both viral and bacterial infections happen in 20 to 30% of patients, and prolonged cytopenias are possible. We have seen late non-ICANS neurologic toxicity. These primarily happen with cilta-cel, including things like Parkinson's-like movement disorders and cranial nerve palsies. It's very important that we have really careful monitoring intervention for any of these toxicities. And we need to ensure that we have tocilizumab available, particularly for CRS, and corticosteroids for patients with ICANS. When we think about delivering CAR T cell early in the line of therapy, we need to be thinking about the process at first relapse and really deciding, is this an appropriate patient for CAR T cell at first relapse, or should we consider it at second relapse? When giving CAR T cell, we typically avoid prophylactic dexamethasone or other systemic steroids. And if possible, we try to avoid prior to CAR T-cell alkylating agents. It's really important when giving CAR T-cell to understand CRS and ICANS, which happen early, early use of tocilizumab, and early use of ICANS. Later on, after that initial period, we need to think about the rare but more serious other neurologic toxicities and risk of infections. All right, what about this 70-year-old? Standard risk myeloma. He lives alone. He lives in a rural area. He doesn't have a full-time caregiver. He also had very good induction therapy, DARA-VRD, consolidation with transplant, VGPR, and lenalidomide maintenance therapy, and he also relapsed. Again, we saw this before, multiple regimens that would be appropriate. Again, this patient is refractory to lenalidomide, so I wouldn't use any of the lenalidomide regimens. Daratumumab or isatuximab plus carfilzomib and dexamethasone would be a good regimen. But as we saw both with DREAM7 and DREAM8, one could consider belantamab mafodotin in combination with bortezomib and pomalidomide in this situation, and then you have a therapy like DKD for later. So these are this is the type of patient, the patient that doesn't have that caregiver support, that it's going to be really important to have a drug like belantamab mafodotin. Now, we know belantamab mafodotin was previously approved, and then after failure of phase 3 studies in the context of ocular toxicity, was taken off the market. Now, if we look at the DREAM7, the new studies, we'll see here that approximately 70% of the patients had any eye-related event. 21% of the patients had grade 3 or 4 blurry vision, and 9% of the patients discontinued due to ocular side effects. And the dosing strategy was the 2.5 milligrams per kilogram every 3 weeks, and again, could be reduced or dose delayed due to toxicities, and then standard bortezomib dexamethasone. There are ongoing studies looking at trying to understand the optimal dosing of belantamab. Could we give every 8-week dosing? Could we give every 9-week dosing? And again, there's several studies that are out there trying to answer these questions. When in DREAM7, in order to the way that ocular examination was done was after the first dose, and then prior to the first dose, and then prior to the first 6 doses. And again, if no ocular findings were found up into the 6th dose, then ocular exams then occurred every 3 months. All right. What about a patient who's had multiple lines of therapy? This is a 72-year-old woman with triple-class refractory myeloma, treatment history, again, good therapy, DARA-VRD, transplant, lenalidomide maintenance, followed by KRD, followed by isapomdex, and then cellular-pomdex. This patient has had a lot of therapies and is progressing rapidly, and performance status is now a 2. This is a patient that I believe would be very hard to proceed with CAR T-cell. Her disease is rapidly progressing. We don't have good standard bridging options. There are currently investigational bridging options, like using a GPRC5D bispecific as a bridging, but that I would consider investigational at this time. So the question is, would this be an appropriate candidate for a BCMA bispecific or GPRC5D bispecific? Because we think this is an appropriate time and not an appropriate right now for a CAR T-cell. In general, the way I think about this patient is, if this patient is ever going to be a candidate for a BCMA CAR T-cell, then I'm going to choose the GPRC5D in this situation. If I don't think this patient is ever going to be able to have a CAR T-cell, lack of caregiver support, the patient doesn't want to spend too much time in the hospital, or other reasons, then it's at this time that I'm going to think about using the BCMA bispecific therapy. In the future, at this moment, if we had therapies like trispecific, would be something that we could consider. The other thing to consider in this scenario, if the patient had extramedullary disease, one could consider a combination that's been studied in the Redirect study of the combination of teclistamab and talquetamab. So here we have the same patient, and this patient, though, already had a BCMA CAR T cell and subsequently had a short duration of response. Again, she's progressing, worsening performance status. And then the question is, what do we do in a patient who's had a BCMA CAR T cell, had a relatively short duration of response? What are we going to think about in terms of therapy at this time? From my perspective, if the patient's had a relatively short duration of response with the BCMA CAR T cell, I'm really going to think about using a different target. It's really important when we think about back-to-back immunotherapies, switching targets, especially when there's a short duration. And again, when we think about back-to-back bispecific, we really want to think about alternative therapies before doing back-to-back bispecifics, if at all possible. So this is a question. This is a patient right now that I'm going to choose the GPRC5D therapy with talquetamab. When we think about dosing, the important thing about the dosing for all of these medications, all of the bispecifics, is that they are all unique to themselves. Teclistamab has a unique step-up dosing to elranatamab, and while teclistamab and talquetamab have very similar step-up dosing, they have different dosing strategies with either the 0.4 milligram weekly or the 0.8 milligram per kilogram every other week. So really the take-home point for this is that each drug has their own step-up dosing strategy as well as initial dosing strategy. The dosing for linvoseltamab is unique in that the step-up dosing is given the first day, and then 1 week later, and then the third week the standard dose. The first linvoseltamab dose is at 5 milligrams with 24-hour observation after the first step-up dose. The second step-up dose is 25 milligrams with the 24-hour observation, and then weekly dosing for the first 3 months, and then every other week dosing after that. And then after 6 months or 24 weeks forward, those patients who have achieved a VGPR better can switch to every 4-week dosing. So this is really an important concept in these bispecifics, in that it's the length between dosing is dependent on the response to therapy. And the better response, the more we're able to stretch out those dosing. There's a lot of investigation for all these bispecifics in trying to move up that stretched out dosing earlier to decrease the toxicity. When we think about toxicity from BCMA, we're really talking about infection. And when we think about toxicity from GPRC5D, we're talking about the on-target, off-tumor toxicities associated with GPRC5D. The management of CRS with bispecifics is important. When we look at the rate of CRS in patients with bispecifics, it's somewhere between 50 and 80%. Fortunately, the percentage of patients who have grade 3 or higher CRS is very infrequent. Grade 1 CRS, supportive care, consider TOSI. Grade 2, where there's hypotension or hypoxemia, again, holding the dose. Tocilizumab, most likely consider steroids. Restart when the AE is involved, when the AE is resolved. And then for patients who are quite ill, who get grade 3, have to have vasopressors, go to the ICU, certainly discontinue therapy at the time. Tocilizumab plus steroids, and resume therapy after careful clinical judgment. We and others have looked at considering the high rate of CRS of using tocilizumab prophylaxis, which can significantly reduce the rates of CRS and promote a potential step-up dosing as an outpatient. Important when we think about infection management, try to get the patient vaccinated. viral testing, looking at making sure the patient doesn't have latent HBV, and antiviral therapy for HBV if any evidence of positivity, monitoring CMV levels, and treating with CMV reactivation. Really must have prophylaxis with PJP and varicella. One would consider prophylaxis with antibacterials and antifungals in the case of prolonged cytopenias. Again, entecavir for prophylaxis with HBV. Very important in patients with hypogammaglobulinemia, and almost everybody will develop hypogammaglobulinemia on the BCMA targeted therapies to administer IVIG for those patients with an IgG, a normal IgG less than 400, regardless of history of infections. This approach of early intervention with IVIG has truly saved lives. I had mentioned earlier the on-target off-tumor toxicities associated with GPRC5D. If you use this medication, it's really important you have to know that these toxicities, and the patients have to know dysgeusia, the bad taste in the mouth, dry mouth, dysphagia, weight loss, skin toxicities, and nail toxicities, all are due to the, again, on-target off-tumor impact of the GPRC5D targeted antibody drug conjugate. And with that, I will reiterate that early use of BCMA CAR T-cell therapy has improved outcomes in patients with relapsed refractory myeloma. We saw that from the CARTITUDE-4 and the KarMMa-3 study. Identifying the appropriate candidates is important. Who do we use at first relapse or second relapse? Those patients with high-risk disease and functional high-risk disease, certainly, and the questions are available of should we be doing this for everybody where it's there who are eligible. Also important is, especially when CAR T cells are used early, to really use effective bridging therapy. I think that's one of the things that CARTITUDE-4 taught us, that effective bridging therapy is critical when we want to decrease toxicity to CAR T-cell therapy as well as improve outcomes. And BCMA antibodies represent a really important, effective, off-the-shelf and sequential options in relapsed refractory myeloma. There's really encouraging data about combining bispecifics in extramedullary disease. We saw really exciting but early evidence on new trispecifics. We saw adding antibody drug conjugates to standard therapy is very effective. And then overall, when we think about CAR T cell and we think about bispecifics and we think about antibody drug conjugates, thinking about and anticipating their toxicities are really critical if we're going to have long-term effective therapy. And thank you for joining us today in this review of new immunotherapies for multiple myeloma.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This educational activity is supported by independent medical education grants from GSK, Johnson & Johnson, and Regeneron Pharmaceuticals Incorporated. To access all materials for this activity, visit peerview.com/PAT860.